CKD patients, especially those ones who are on dialysis and those ones who have received renal transplant. So FGF23, when it's high in the serum and the patient has normal serum phosphate levels within normal range, so what is your next step? This can be a potential exam question. When the FGF23 is normal and when it's high and the serum phosphate is normal, then what will you do? You will not wait for the serum phosphate to increase. You will not wait for a hyperphosphatemia episode. You will start therapeutic intervention, not dietary restriction, but therapeutic intervention, which is from phosphate restriction. That is, what will you do? You will give phosphate binders. Very important. So increased FGF23 levels may be one of the earliest detectable biomarkers of renal osteodystrophy, and before that, secondary hyperparathyroidism. So this is what happens. You have to prevent the hyperphosphatemia you have to prevent the patient who has hyperphosphatemia from these complications. So now this secondary hyperparathyroidism, it has effect on bone. It stimulates bone turnover and eventually leads to osteitis fibrosa cystica. Osteitis fibrosa cystica forms abnormal osteoids and causes bone fibrosis and formation of bone cysts. But clinically, patient presents with bone pain and fragility and clinically brown tumors. And this is very important. It can also cause erythropoietin resistance. This can be a potential exam question. Now, hyperparathyroidism stimulates bone turnover and leads to osteitis fibrosa cystica. And this secondary hyperparathyroidism you have to remember this, because secondary hyperparathyroidism can cause this bone abnormality due to increase in bone turnover. But when the PTH is there is a point comes when the PTH is suppressed, and this causes low bone turnover. Low turnover bone disease is known as a dynamic bone disease, and the second low turnover bone disease is known as osteomalacia. Okay, you have to remember this. This is caused by suppression of PTH, which can result from the use of vitamin D preparations or from excessive calcium exposure in the form of calcium containing phosphate binders or high calcium dialysis solutions. So this is very important. So low bone turnover can lead to a dynamic bone disease and osteomalacia, and a high bone turnover can lead to osteitis fibrosa cystica. This is extremely important. Please remember these concepts. Now, hyperphosphatemia can also cause secondary tumoral calcinosis. What is secondary tumoral calcinosis? It's a dermatological complication of later stage CKD. What happens that retained phosphate complexes with calcium, and it goes and deposits in subcutaneous tissue and the skin. How will you differentiate familial tumoral calcinosis from secondary tumoral calcinosis? Well, familial tumoral calcinosis is autosomal recessive, and you can go for a blood sample and check out the genetic sequencing. In familial tumoral calcinosis, you will see a gene mutation, GALNT3. GALNT3 gene mutation occurs, and you can check that out by doing genetic sequencing. And secondly, in familial tumoral calcinosis, serum calcium and PTH levels are normal. So this was all about the main complications of hyperphosphatemia. You have to prevent the patient from having these complications, and that's why you have to immediately start the treatment of the patient. Now, how will you treat the patient? Again, the treatment is stratified on two categories. It depends whether the patient is receiving dialysis or not. If the patient, say CKD, is not on dialysis and hyperphosphatemia is there, means hyperphosphatemia is above 4.5 mg per dl. So what will you do? The first and foremost step is restrict dietary phosphate. Restriction. Why is restriction of dietary phosphate important? question. It can normalize the PTH level. Restriction in dietary phosphate has the ability to normalize PTH, serum PTH level. How much will you restrict? You have to give moderate restriction. What is moderate restriction? It's when you are giving phosphate around about 900 mg per day, right? Now, if this doesn't work, then you go for a phosphate binder. Now, if a patient who is having CKD and not on dialysis, and you check the phosphate and it's above 6 mg per dl, then as per up-to-date guidelines, what will you do? You will concurrently start phosphate binder and restriction of phosphate intake. Now, when you give a phosphate binder, how do you monitor response to therapy? So you are monitoring definitely serum phosphate and 24-hour urine phosphate. Another question, 24-hour urine phosphate along with the serum phosphate. How often do you monitor? Usually at 3 months, 6 months, 9 months. Now, what's the other benefit of phosphate binder? Another potential exam question. Phosphate binders have the ability to stabilize PTH. Phosphate binders have the ability to stabilize PTH within normal range, which means that a phosphate binder can prevent a secondary hyperparathyroidism and eventually renal osteodystrophy. So this was about a patient CKD who's not on dialysis. Now a patient with CKD on dialysis. What is the normal serum phosphate range? Which is the acceptable serum phosphate range? It's between 3.5 to 5.5 mg per dl. Okay, in dialysis patient with CKD, serum phosphate has to be between 3.5 to 5.5 mg per dl. If serum phosphate goes beyond 5.5 mg per dl despite of dialysis, what is the next step? You have to give concurrent, number 1, restrict patient's phosphate intake, dietary restriction, number 2, phosphate binder, and number 3, you have to change the mode of hemodialysis. Why? Now, standard hemodialysis is not enough for a patient who has hyperphosphatemia and CKD. Now, why? Because standard hemodialysis only extracts not more than 900 mg per day of phosphate in one hemodialysis standard session. What is standard hemodialysis? It's when you give like 3 hemodialysis sessions and one session is 4 hours. This is the protocol. But this does not work in a patient with hyperphosphatemia. Often it does not work. So now what will you do? You will change the mode of the standard dialysis. Because of its limited ability, definitely you have to change the mode in order to remove more phosphate. What will you do? You will consider, number 1, a daily hemodialysis. Daily is known as frequent hemodialysis or nocturnal hemodialysis. Nocturnal is usually prolonged and it's like almost the night. So this is known as prolonged hemodialysis. Now, a frequent hemodialysis and prolonged hemodialysis both have the ability to remove greater amount of phosphate and then eventually substantially lower the serum phosphate levels. This is extremely important. So yes, the phosphate binders in a patient who is on hemodialysis, phosphate binders has the ability and the benefit of decreasing cardiovascular mortality. This can be exam question. Now let's talk briefly about the phosphate binders. There are 2 types of phosphate binders, the calcium containing phosphate binders and the non-calcium containing phosphate binders. The main examples of calcium containing binders are calcium carbonate and calcium acetate. And then major non-calcium containing binder is sevelamer, sevelamer. Okay, now the calcium containing, it's really not preferred because number 1, it can increase calcium vascular calcification. It can worsen the calcification in the coronaries. It can worsen definitely hypercalcemia. And how? By positive calcium balance. Okay, the total positive calcium balance exacerbates. This causes worsening of the calcification in the coronaries and the cardiac valves, and definitely it also has the ability to cause a dynamic bone disease. because it suppresses PTH levels. So a dynamic bone disease occurs by low bone turnover. Low turnover bone disease can occur. A dynamic bone disease is the commonest one. Okay, and so sevelamer has, as I mentioned before, decreases the cardiovascular mortality, and it's preferred over calcium containing binders. So yes, sevelamer is the best one because it does not cause vascular calcification and it decreases the cardiovascular mortality. So this was all about the treatment of hyperphosphatemia in a patient with CKD. Now, hyperphosphatemia has so many other causes. There's not one cause to it. Hyperphosphatemia in CKD patients, it's caused mainly by decreased renal clearance. And the decreased renal clearance is because of reduced GFR. A reduced GFR is responsible for decreased renal clearance. There are other causes in the kidney that can increase the phosphate level, like increased proximal tubular reabsorption. There are diseases that affect directly the proximal tubular reabsorption and increase phosphate in the serum, like hyperparathyroidism, pseudohyperparathyroidism, familial tumoral calcinosis, acromegaly, and drugs like bisphosphonates, vitamin D toxicity, cinacalcate. All of these are responsible for increasing tubular reabsorption of phosphate. There are other causes that are responsible for hyperphosphatemia mechanisms, like acute phosphate load. When acute phosphate load is high, for example, in cell lysis like tumor lysis syndrome and rhabdomyolysis, or because of exogenous causes like drugs like phosphenytoin and laxatives. And before you prepare the patient for colonoscopy, that's also exogenous cause of hyperphosphatemia. So yes, acute phosphate load can cause hyperphosphatemia. Decreased renal clearance can cause hyperphosphatemia. Cellular shift like ketoacidosis can cause, or lactic acidosis can cause hyperphosphatemia. Then there are pseudo hyperphosphatemia, in which you're not using the correct analytical methods. So, for example, the most common causes that are responsible for pseudo hyperphosphatemia is drugs like diseases like multiple myeloma, and there are other causes like drugs like liposomal amphotericin B. It causes extreme pseudo hyperphosphatemia. And once the IgG levels or any type of globulins are high, this hyperglobulinemia is also responsible for pseudo hyperphosphatemia, and so is hyperlipidemia, hyperbilirubinemia. But you have to remember this drug, liposomal amphotericin B, is responsible for pseudo hyperphosphatemia, and other drugs that you can remember that are responsible for this spurious hyperphosphatemia are tissue plasminogen activator or heparin. So this was briefly all about the treatment of hyperphosphatemia in a patient with CKD. If you have any questions, you can email me. My email is on the blog. And I hope you liked it. Please pass your comments and give your feedback. I will appreciate it. Have a nice day. Take care. Bye.